I'm Professor Fidelma Dunn and I'm a consultant endocrinologist at Galway University Hospital. I've been looking after ladies who have diabetes in pregnancy for 20 years and with my colleagues have developed this web set of videos to provide education for you, the person with diabetes, so that you understand the importance of preparation for pregnancy, regular attendance during the pregnancy, and a follow-up visit post the delivery of your baby for ongoing care. Type 1 diabetes is where your pancreas produces no insulin. You are totally insulin deficient, and because of this you need insulin from the time of diagnosis. Your treatment will always be insulin. Type 1 diabetes affects 1 in every 250 pregnancies. It is very important that your blood sugars are well controlled with the appropriate amount of insulin before you become pregnant, at the time your baby is developing in the first 7 weeks, throughout the pregnancy and post-delivery, to ensure that the outcome for you and your baby is at its best. The outcomes for pregnancy for women with type 1 diabetes are not as good as the background population. However, we can reduce the risks in the pregnancy significantly to approximate that of the background population by proper preparation. Pre-pregnancy care involves a period of time before you become pregnant for about 3 to 6 months, where your diabetes team will manage your diabetes very intensively to ensure that we get your blood sugar normal before you become pregnant. Through the pre-pregnancy service, we will address a number of factors that we know affect your pregnancy outcome. One is your blood sugar control. We would like your fasting sugar and your before meal sugars not to be any higher than 5, and your 1 hour post meal sugars not to be any higher than 7. In addition, you are aware of the long-term blood test that we use to manage your diabetes. This is called a HbA1c. We strive to ensure that your HbA1c is normalised, that is, not any higher than 6%. At the pre-pregnancy service, we will also prescribe for you folic acid at a higher dose of 5 milligrams. We give you this for 12 weeks, and this is to contribute to a reduction in congenital malformations of the baby that may be associated with the presence of diabetes. In addition, we examine all of the rest of your drug treatment, as many of these are not suitable for pregnancy. We will provide you with alternative treatments that are pregnancy friendly and do not impact on your baby. We will discuss with you about your weight and your body mass index, as normalising these has important consequences for the pregnancy also. We will ensure that your kidneys are checked and that your eyes are checked and that your blood pressure is checked to ensure that these are normal before you start the pregnancy. Should you have any problems with any of these areas, we can deal with this before the pregnancy starts. We will do a number of blood tests. These are to check for rubella, for kidney function, thyroid function, vitamin D, hemoglobin, and your HbA1c. You will have intensive one-to-one discussions with the diabetes nurse specialist and the dietitian, so that the principles of good dietary intervention can be revised, that blood sugar targets are given to you, and that you know how to deal with episodes of hypoglycemia should and if they occur. We will see you at the pre-pregnancy service every 2 to 4 weeks, during which time you will take appropriate contraception, and once all your parameters are normalised, then that is the most appropriate time for you to become pregnant. Your care will now transfer from the pre-pregnancy service to the antenatal service. However, it will generally be the same people looking after you as we employ a team approach. The people you will see are a diabetes physician, a diabetes nurse specialist, a dietitian, a midwife, an obstetrician, and an ultrasonographer. It is very important that you attend the clinic regularly, and your appointments will be given to you every 2 to 4 weeks as required. At each clinic visit, we do a number of routine checks. These include your weight, your blood pressure, a check of your urine, and regular blood tests of your sugar control. We review your medications, and we adjust your insulin to ensure that we keep your sugar tests normal. You will have scans carried out routinely at different times during the pregnancy. Initially, the first scan is to ensure that the date of your pregnancy is correct. This is important when we are organising the time of your delivery. The next important scan is in the middle of the pregnancy, and this is to have a detailed look at your baby to make sure that everything is developing normally. Towards the end of the pregnancy, we do more frequent ultrasounds, and this is to ensure that the growth of your baby is occurring at the normal rate and as planned.
As part of your specialist care, you'll be given advice on regular activity and exercise. And the reason for this is we know that it lowers blood pressure, it helps control cholesterol, it helps your blood sugars, and many, many more important factors. To get the benefits, you'll be advised to do 150 minutes spread over the week of moderate intensity activity. So one example would be 30 minutes a day. It's important to start off gradually and build up slowly, picking gentle activities, things like walking, swimming. You can seek advice from specialist care. The most important thing is it's enjoyable, it fits into your daily routine. Irrespective of the type of diabetes, it's important to check your blood sugars before and after you exercise. And you may need a snack in order to help prevent low blood sugars. It's important if you're on an insulin pump that you think about checking your basal rate for exercise purposes as well. You'll be getting more advice on a one-to-one consultation to give you a personalised programme to help you get the most from your activity.
A diabetic should always follow a healthy, balanced diet, but this is especially important during pregnancy. Follow a healthy, balanced diet. Eat regular meals with a small portion of high-fibre carbohydrate food at each meal. Eat plenty of vegetables and limited fruit. Avoid added sugars in your diet. Breakfast needs to be small. A healthy diet contains a balance of foods to support baby's growth. The food pyramid is a good guide of how much of each food you need every day. Your dietitian can help you with meal plans that suit your own needs. There are 3 basic nutrients in food: carbohydrate, protein, and fat. Carbohydrates provide us with most of our energy. Carbohydrate foods turn into sugar or glucose after you eat them. It's important that these foods are eaten in small quantities throughout the day. Include a small portion of starchy carbohydrate at each meal. Choose high-fibre, whole-grain options. Protein is essential for your baby's development. Protein is found in meat, chicken, fish, eggs, peas, beans, lentils, tofu, nuts, and cheese, and will not turn to sugar when you eat them. Fats do not turn to sugar, but should be limited in your diet. One special fat, omega-3, should be increased in your diet. The best source are oily fish, such as salmon, trout, mackerel, sardines, kippers, and herring, and you should aim for 1 to 2 portions of oily fish per week. Vegetarian sources of omega-3s include soya, walnuts, and rapeseed oil. The following are types of carbohydrate foods: starches, milk and yogurt, fruit. Starches. A small portion of high-fibre carbohydrates should be eaten at every meal. Milk and yogurt are good sources of calcium. Choose sugar-free yogurts, diet or light, and limit your milk to no more than 3 glasses of 200 ml each day. Eat plenty of vegetables and a limited amount of fruit. It's best to avoid fruit juices and smoothies. Avoid dried fruits such as raisins, sultanas, dates and apricots, and eat only one piece of fruit at a time. Avoid added sugars in your diet. Sugar and sugary foods like chocolates, sweets, cakes, honey, jam and fizzy drinks, and sugar and chocolate coated breakfast cereals. Avoid foods labelled diabetic or made with sugar alcohols like sorbitol, malitol, xylitol. They're often high in fat and can cause wind bloating and diarrhea if you eat a lot of them. Some medicines, like medicines for heartburn and constipation, contain sugar. Make sure all the medications you're taking are sugar-free. Speak with your doctor or pharmacist about sugar-free options that are safe in pregnancy. Include a small breakfast each day. Blood sugars tend to be higher in the morning. In summary, to keep your blood sugar levels under control during pregnancy, eat 3 meals and some snacks spaced evenly over the day. Limit portions of carbohydrates. Avoid added sugars and sugary foods. Include a small portion of starchy carbohydrate at each meal. Limit fatty or fried foods and takeaways. Do not skip meals and drink plenty of water and other sugar-free drinks throughout the day.
I'm Brita Kerwin. I'm a diabetes nurse specialist. You will probably have met a person like me throughout your pre-pregnancy care who will follow you through your antenatal care and delivery, who will personalise your care with a multidisciplinary team and help you achieve your goals. As part of your package, we will highlight some issues which may arise throughout your pregnancy, which will have to be dealt with promptly and correctly. Hypoglycemia, an event which often occurs in the first trimester, where we're keeping very tight control on your sugars. We will have prepared you and your partner and your family to detect, treat and prevent this occurring.
Hypoglycemia. Hypoglycemia, or hypo, is the term used if your blood glucose levels go too low, below 3.5. This can happen for a number of reasons, such as delayed or missed meals, not eating enough, vomiting, too much exercise at one time, inaccurate dosing of insulin, alcohol, hot weather, breastfeeding. You'll learn how to recognise your own early warnings of a hypo, and these may include nervousness or anxiety, shakiness, sweating, tiredness, confusion or hunger. If you experience any of these symptoms, you should do a blood sugar test to check your level. If your level is below 3.5, you're having a hypo. To treat your hypo, take 15 grams of fast-acting carbohydrate that contains sugar, and this is provided by one of the following: 5 glucose tablets, 100 ml of Lucozade, 150 ml of pure fruit juice, not diet, or a sugary drink such as Coke. Follow this with a slower acting carbohydrate like fruit, bread or breakfast cereal. Check your blood glucose levels again after 10 or 15 minutes. If you're still below 3.5, repeat the treatment and test again until your level comes up. Remember to always carry glucose tablets or some form of sugar with you. Severe hypoglycemia. If the episode progresses very quickly or the warning signs are ignored, you may not be able to administer your own treatment. You may have to rely on family or friends, which is why it's vital they understand what to do. The signs and symptoms of a severe hypo include poor concentration, slurred speech, glazed eyes, poor coordination. You may appear to be drunk, confusion, drowsiness, or a loss of consciousness. Immediate action must be taken. If you're conscious and it's safe to swallow, have some sugar. The liquid form is easiest. Or 15 grams of fast-acting carbohydrate, glucose sweets, sugary drink, fruit juice, and once you start feeling better, check your sugar. Again, follow this with a slower acting carbohydrate like fruit, bread, or breakfast cereal. Explain to your family and friends what to do if you pass out or become unconscious, which is the following: place you in the recovery position and inject you with glucagon. If glucagon is not available, call 999 immediately for medical help. Insulin should never be given to an unconscious patient. Always report a severe hypo to your nurse or doctor.
Hyperglycemia, ketoacidosis, a serious medical condition. This indicates that your body is lacking your essential insulin, which also creates a state of dehydration in your body. This condition, if untreated, allows your body to develop acidosis, which can be threatening to your unborn baby and also to the maternal health. This can be caused by nausea, vomiting, an untreated infection like a urinary infection, or omission of your insulin. In preparation for your pregnancy, we have given you the skills to help you cope with detecting and treating this type of condition. Morning sickness, which can often last for up to 16 weeks. Once the first trimester is completed, hopefully this will leave. It can be difficult for mothers with type 1 diabetes, with reducing their insulin requirements and increasing the risks of hypoglycemia. Therefore, it's important to eat frequently and never miss your meals. If the symptoms are severe and you're unable to eat or drink, or you become ketotic, it's very important that you seek urgent medical advice and treatment to correct this condition in your body. Preeclampsia, a medical condition which usually occurs in the last trimester of your pregnancy, associated with an elevated blood pressure and also the detection of protein in your urine. You may also have some swelling of your lower limbs and fluid retention. This condition warrants that you will have to have treatment, i.e. an early delivery of your unborn baby or medical treatment in hospital requiring stabilisation of your blood pressure. Retinopathy and nephropathy. Two conditions, if you have already existing eye disease or kidney disease, may deteriorate throughout your pregnancy with extra demands of the pregnancy. We will monitor very closely. In each trimester, your eyes will be screened, and at each clinical visit, we will screen your kidneys. Early detection of deterioration of these conditions will be promptly treated by your physician. Preterm labour. This term describes a labour which has occurred before the baby is fully developed. It may occur before 37 weeks gestation. In this instance, your baby may require specialist treatment in the special care baby unit. Polyhydramnio, an increase in the amniotic fluid, the fluid in which your baby floats. This can indicate poor glycemic control and often prompt a premature labour. But with the increasing of your insulin doses and better glycemic control, often this polyhydramnio can be reduced.
The majority of women deliver at term, which is considered to be 37 to 40 weeks. There are a small number of women who need to be delivered before term, and this delivery is sometimes warranted if your health or the baby's health is at risk. If your delivery happens at term, you may go into labour normally yourself and have a normal vaginal delivery. This happens in the majority of women. Should this be the case with you, you will continue to take your insulin as prescribed and as planned until you are in the active stage of labour. At that point, the midwife looking after you will change you to a drip which contains glucose and insulin. This is important as the midwife will then be able to regulate your blood sugars between 4 and 7 for the duration of the delivery. It is important to keep your sugar during this important period of time between 4 and 7 to ensure that your baby's sugars are normal when it is delivered. If your obstetrician decides that a caesarean section is the best form of treatment for you, this is usually planned and you will be given a date for this delivery. You will be brought into hospital generally the night before, and you will continue to do your own insulin and your own sugar testing up until the time you go to sleep. After that, you're not allowed to eat or drink. On the following morning, the midwife or doctor in charge of your care will put you on a drip early in the morning. This will contain glucose and insulin, and once again, the doctor and the midwife caring for you will regulate the drip and the insulin to keep your sugars normal. You will not need to think about your sugar or your insulin requirements yourself. If your obstetrician decides that he needs to induce your labour, you will continue to take your insulin as prescribed normally until the induction of labour has placed you into the active stage of labour. At that time, the midwife once again will place a drip and an insulin infusion in your arm and continue to regulate your sugars, keeping it between 4 and 7. Once again, you will not need to worry. Once your baby is delivered successfully, be that by a normal delivery or by a caesarean section, your insulin requirements are reduced by about 50%. This is a normal phenomenon. The nurse, midwife or doctor caring for you will reduce your insulin in your drip to account for this. With regard to your baby, the vast majority of babies delivered to mothers with diabetes are perfectly normal post-delivery. However, a small number of babies will have or display low sugars following delivery. Because of this, their sugars are measured regularly in the first number of hours. It is important that you feed your baby early and then continue to feed your baby on demand to ensure that the sugars remain normal. In most cases, your baby will return to the ward with you and be nursed by you following delivery. A small number of babies may require neonatal unit care for a short period of time if they have problems with their blood sugar or they have problems with their breathing. This would be unusual, however. For women with diabetes, we recommend that you breastfeed your baby if possible. You will be given a lot of encouragement to do this, and you will be given a lot of help post-delivery to make sure that the process occurs without any undue stress to you. Breastfeeding is very important for your baby and will also help in the control of your own sugars and your body weight following delivery. And you are now back to see us for a postnatal check. This again is very important to ensure that there has been no change in your diabetes over the period of time of your pregnancy. During your postnatal visit, we will review your medications again and ensure that you are replaced on the medications that are appropriate for your diabetes management long term. We will also review your diabetes management in terms of your insulin doses, as these will now adjust downwards post the delivery and post your period of breastfeeding. We will arrange for you to have your eyes rechecked again, and we will ensure that your follow-up diabetes management is back in the general diabetes service. We will enforce principles of good pre-pregnancy care again and ensure that you have all of the phone numbers and contact details of those people in the pre-pregnancy service so that you can come in a timely fashion again prior to your next pregnancy.
So my name is Cliona Dempsey. I'm a type 1 diabetic. I was diagnosed when I was 32. I had got married at age 30 and had started trying to conceive straight away. I wanted to have my family young and was hoping to have a couple of children. 2 years into that journey, I still wasn't pregnant, and completely out of the blue, I was diagnosed with type 1 diabetes, which was a complete shock to me. At the time, there was no history in the family. I knew nothing about the condition, and it terrified me. I was in hospital for having investigative things done, and this came to light during that. And my sugars were very, very high, so my conceiving was put on hold until I got my sugars in control, because I was informed at the time of the risks associated with high blood sugars in pregnancy. So it was a very traumatic time because I was so nervous and worried and terrified of everything. I also felt that, you know, my desire to have children was now gone on hold even further. But I started attending the pre-pregnancy diabetes clinic under the care of Professor Fidelma Dunn, and with her support and the clinic there, I was seen every month. And they got me ready for pregnancy. It was an extremely challenging time because I knew nothing about what I was doing. I was trying to keep my sugars in control. And when it's a new condition, you know nothing about it, it's very hard to suddenly switch things on and know what to do. I think they got me ready for pregnancy, but I also had fertility issues, so it took another 4 years for me to get pregnant, which was very, very challenging because I had to keep my sugars in very tight control for those 4 years. Sometimes, if I be honest, I thought about giving up because the fear of going through pregnancy, having to get pregnant first, then going through pregnancy, and then having to deal with complications was very worrying, if I'm honest. But the desire to have a child was way too strong. So after various fertility treatments, including 3 rounds of IVF, I got pregnant. And I was immediately transferred to the gestational diabetes clinic, again under the care of Prof Dunn and Breda Kerwin from Galway. And they aggressively managed my condition with me, which was fantastic. The care I got was completely outstanding, exceptional, unbelievable, to be honest. I was seen at a clinic every 2 weeks. I was scanned every 2 weeks. I had blood tests done every 2 weeks, blood pressure. My sugars were gone through. And every bit of care and support I needed was given. And because of that, I think I had a successful outcome. My baby was born in 2011, a little beautiful, healthy little boy. Everything went well. I had a caesarean section at 38 weeks. I was not at all bothered by that. It was very straightforward, and I wouldn't worry. If any woman's worried about that, don't be, because you're looked after so well in the hospital. And you know, while diabetes is horrible and it can be so hard to deal with, and it really can, and it's 100 times worse during pregnancy because you do your best and you still get everything wrong, and your hormones are changing and your level of activity is changing, and you're not sure of the content of sugar in food, and it's all very, very challenging. But they're there, the clinic are there at the end of the phone, and Breda rang me every 3 days, and they're great. And you know, it's there. I knew that they were going to get me there, you know, and they did. And I would say to any woman, don't be afraid, go for it. It's so worth it.